Namaskara. My name is Dr. Rajeev Vijayakumar. I'm a consultant in medical oncology, hemato-oncology, and I'm a BMT physician. Today, we're doing this live streaming session. We're going to talk about bone marrow transplantation. This is something, a topic which many people have a lot of queries about, and they have a lot of doubts, a lot of myths regarding it. People come and ask me, Doctor, when you do the bone marrow transplantation, you cut the bone of the donor and then afterwards you give it. So right from my badminton class to my sessions to my sessions in the club, this is a very common question. I realized that so many people ask me so many things about bone marrow transplant, and most people don't have probably even an idea as to what exactly it entails. Then so many times physicians ask me, my colleagues, I don't blame any of them because oncology is such a topic that we are not taught very much in medical school. So therefore, my dear friends, today's session, we're going to talk about what is this bone marrow transplantation? In whom do we offer this therapy to? Is it for every patient with a cancer? Is it only for blood cancer? Is it for every patient with a blood cancer? How long does it take? Is it a surgery? Do you take the patient into the operation theater? How long does the surgery last? Questions that are there. Well, stay tuned till the last. We'll be able to explain all of these to you. So I'm going to divide my talk today so that it's easier and it's easy on the mind as well, and you can also judge your time. You can spend your time appropriately. I'm going to talk about one and introduce it, then afterwards talk about stem cells, then what exactly is the bone marrow transplant, then indications, when do we use it, then pre-transplant evaluation, safety, outcomes in the recovery, and then the common myths and the clarifications that we have, and then the key take-home messages. So let's start with the introducing the topic to you. So now cancer has grown by leaps and bounds, and the therapies have increased even a multitude of number of times. So in the early years, when we were giving therapies for blood-related cancers, especially like acute leukemias, multiple myelomas, lymphomas, these are the blood-related cancers. Then we had certain non-cancerous diseases like myelodysplastic syndrome, myelofibrosis, and then thalassemias and sickle cell anemia, aplastic anemia. So typically we can divide our where do we use bone marrow transplant into two categories. One is cancerous hematology, one is non-cancerous hematology. In kids, it is the non-cancerous hematology which is maximum. That is like thalassemias. Thalassemias is a disorder of the hemoglobin where they come with repeated blood transfusions. The children don't grow too tall. We will talk about that on another sitting, but for you to just understand. Then there is sickle cell anemia, where the RBCs, that is the WBCs, that is the blood cells in the body, they start getting broken down. That is sickle cell anemia. Then after you have aplastic anemia, which is a bone marrow failure syndrome. The RBC, WBC platelets don't get produced. Then you have other conditions like myelodysplastic syndrome and myelofibrosis. Even in these conditions, there's an aberrations or changes in the blood counts. And those apt patients, after failure with oral tablets, will need a bone marrow transplant. Now, talking about the malignant hematology or the cancerous part of it, you have acute leukemias, you have lymphomas, and you have multiple myeloma. Now, this is the simple thing that you need to understand. So, before that, let us understand what is this bone marrow and what are these stem cells. So, normally, a non-vegetarian person would have probably taken the bone of from a mutton or from a chicken, then afterwards handed it, and then inside the bone you would have found the marrow, and then which people slurp. So the same thing happens inside our body. That is the area of production of the RBCs, WBCs, and platelets. So this is like a well, like in our house that we have a well. The depth of the well is where the water is. Similarly, inside the depth of the bone is where the bone marrow is, and from the bone marrow, the RBCs, WBCs, and platelets are produced. So blood-related cancers originate from that particular well. Lymphomas originate in lymph nodes. leukemias and myeloma originate inside the well, that is the bone marrow. So if it is diseased, you need to change it with a person with a proper HLA type match. It could be a sibling. Most of the times it is a sibling, or that is a brother or sister who has an exact match. Like we say in Jataka, right? It's like Ishtu Kundli, so much match. Similarly, we have the original Kundli or Jataka, which is 12 by 12 match. We look at 12 gunas. All of these, if they correctly match, that person would be the apt person to donate. So in these, we have something called stem cells. That is like from the garbham or from the womb, these cells normally keep multiplying and then it forms into a baby and then it forms into a human being, right? Similarly, inside the bone marrow, we have these stem cells. These stem cells start multiplying. They would form, some of them would become RBC, some of them WBC, some of them into platelets. So it is these stem cells that we harvest, store it inside the refrigerator or into a deep freeze around minus 190 degrees centigrade, and then from these stem cells, you're all the, that is the life or the punarjanma of the cells of the bone marrow, which are kept separately. Now, talking about what is a bone marrow or stem cell transplant. So this is a medical procedure. This is not a surgery. We don't take the patient into the operating theater. We do it inside a very clean room, wherein what we do is, there are two types. First, two, three types. Let me talk to you about the different types of transplant. We have something called autologous transplant, allogenic, and haploidentical. You might have also heard of something called as a umbilical cord transplant. Let's talk about autologous. Autologous means from the self. So therefore, if a patient has a condition like a multiple myeloma or a lymphoma, there what do? We give a lot of chemotherapies, take the disease away almost completely. It's nearly removed completely. His bone marrow is fresh without much of any disease. Then we give some injections, increase the number of stem cells. Then using a catheter, we remove the stem cells from his body, run it through a machine, like how they would take separate platelets. Similarly, stem cells are also separated. It's around a 6 to 8 hour procedures. Then it goes inside a particular bag. That bag is kept separately and refrigerated. Then you give high dose chemotherapy to the patient. There is in myeloma and lymphoma. You give, it's called conditioning regimen. You give around high dose chemotherapy, and then all of his good cells, bad cells, everything dies. So then on a particular day, that is on day 0 of the procedure, you take the stem cells which you already harvested and put it back into the patient. So there is patient's own product stem cell which you harvested is called autologous stem cell transplant. If you take the similar situation in certain lymphomas, then in leukemias, where the whole bone marrow itself is completely infested with the tumor, there what you want a healthy marrow. That time what you do is you do an HLA typing, like I told you about the gunas, the 12 by 12 gunas. You identify a brother or sister with the 12 by 12 gunas. If you don't identify them, you identify something called matched unrelated donor. You might have heard of these bone marrow registries. So they identify some people in the world who will have a proper 12 by 12 match with you. Like we've all seen in the movies, right? There are 7 people who look like you in the world. Similarly, you have a lot of people who have an HLA match with you. They have exact correct 12 by 12 Janam Kundli match with you. You can't get married to them, but I'm just saying that you will have in case you need or in case they need, either of them can give the bone marrow as a donation to them. So in allogenic transplant, you will take from the donor. So donor also, there's a small procedure that is done. The donor doesn't have to bother. There's not much of a problem that the donor is going to have. We ensure that the donor doesn't have any infections, doesn't have any cardiac problems, etc. Take the marrow from the donor and give chemotherapy to the recipient, that is the patient, knock off his bone marrow, and then afterwards infuse the fresh, healthy stem cells from the donor into the patient through an IV line. Again, you don't have to poke the bone of the patient. Everything is done through IV lines or intravenous lines. Collecting the stem cells, storing, then giving it back. Everything is through intravenous lines. This is allogenic, that is, you take it from another person. And then here in allogenic, you have matched sibling, that is like I told, 12 by 12 guna. Sometimes you will not find that exact 12 by 12 guna. You might not find the correct person, that matched unrelated donor also you might not find. That is one of the 7 people in the world. There, what do? You can even do something from the parents. This is done especially in youngsters, like kids. The parents would have 6 by 12 match minimum with the child. Both the parents, biological parents, will have a 6 by 12 match. You can, so even this is called haplo, HAPLO, haplo identical bone marrow transplant. So in conditions like sickle cell anemia, thalassemia, this is very, very common, and sometimes even in leukemias, acute leukemias. So we've done one child with my colleague for a child with aplastic anemia, 10-year-old child, where we took the stem cells from the father and gave it to the child. So here too, but here you have to play with your immune suppressants, because the body will try to reject the graft. So basically, this is the information that we need to know. We studied about autologous, then allogenic, then haploidentical transplant. Something we missed out: umbilical cord transplant. All of us have been getting this question, right? Oh, the companies will come and tell you, save your child's umbilical cord blood. It might be useful at some point in time. They don't tell you what exactly it is useful for, because honestly, no one knows. But in some parts of the world, this has been tried, where you take pooled umbilical cord blood from similar HLA typing from the blood bank or from the umbilical cord bank, and that is used for certain patients. It came in a big way sometime back, but now it is not very widely practiced. The standard which we use is autologous for myelomas and lymphomas, allogenic for blood cancers called leukemias, and allogenic is also used for non-cancerous hematological diseases like thalassemia, sickle cell anemia, aplastic anemia. And then you have haploidentical. Wherever this haploidentical is, if you don't find a matched sibling, there you can use a haploidentical transplant. Now, indications which I've actually told. Now, suppose let's consider some member of your family, or even for curiosity's sake, you want to understand what is a pre-transplant workup. So we have 2 types of workups that we have. One is for the patient, that is a recipient, and one is for the donor. Patient, we will again check whether his, because we have to give hydro chemotherapy, we have to do a lot of work. We check whether he's got any infections in his body, in the lungs especially, in the sinuses. His heart is doing well, lung is doing well, rest of the body systems are doing well, no infections. We look for some infections called cytomegalovirus or CMV. We look for, of course, with the rest of the other infections. Then we do a psychiatric counseling, we do a video counseling with the patient. For the donor, we identify that the donor should be fit, should not have too many cardiac problems, should not be badly diabetic. If all of these are controlled, they can be a donor. We also do a psychological counseling for the donor as well. And then we look at their IV lines, both at the peripheral as well as their thigh lines. So we again look into their cardiac functions, lung functions, etc. Infective profile. We don't want a patient to develop infection because of the stem cell product which they have received from the donor. Some infections can be transmitted, so therefore a good stringent checkup is done for the donor as well. It takes around 2 to 3 days. Then after the donor is fixed, then and especially when they have an HLA match, that is a 12 by 12 or a 10 by 12 guna match, we take up that donor for stem cell collection. Now, how safe is it today? So now safety again comes for 2 people. One is for the donor and one is for the recipient. So now how safe is it for the donor? Most of the times donor would have no problem. What we do is, for collection of his blood, we put a small dialysis catheter into his thigh so that we have good flow of blood. So his BP should be good. He should not be having any infections. He should not be having any major cardiac problems. If that is not there, it is just the blood goes into the system, comes out, the stem cells or products are all removed, and then the rest of the blood is sent back into him. This will take around 6 to 8 hours. He should be able to tolerate it. If the donor is a small child, like sometimes like in thalassemia or in sickle cell, you might have 2 siblings. One is a sick child and one is a healthy child. We're taking it from the donor, the child, then we access it from the bone marrow, that is from the hip joint. We take the stem cell harvest. There we put the child under anesthesia and take the marrow from the his bone marrow, that is from the hip joint, or we call this the iliac crest. That the child is under anesthesia for 2 to 3 hours, and then we take the marrow stem cell out. And so therefore, those that kid would need to be under anesthesia. So we will do those kind of analysis to ensure that the child is fit to go under anesthesia and then come out of it. For an adult, it is very safe, because almost never do we find any problems for the donor. Let's talk about the recipient, that is for the patient. Now, the biggest pitfall is when you're in a patient who's undergoing a bone marrow transplant, you are going to give a very high dose chemotherapy induction regimen. When you give a high dose induction, you're killing away the bad cells and pulling away the good cells as well. The question that people ask is, doctor, you've killed all the good and bad cells. You're giving the stem cell product. What if it doesn't engraft? Yes, that problem was occurring in the past. Now with better techniques, that engraftment is much better. There are problems. What we could have patients counts could be very low for a long period of time. So in these situations, we need to use blood and platelets like water. We need to have almost for around 6 to 8 days or 10 days. We'll be giving blood and platelets on a daily basis, because to keep the system up and running till the engraftment occurs. Engraftment means the stem cells which we give right from the donor, those will go into, we give it in the hand, it goes inside, it homes into the bone marrow niche, we call that bone marrow niche. It enters into that and starts sprouting. It's like you putting a seed into the soil. It will take some time for the sprouts to occur. Its sprouting occurs by around day 12 to day 15, sometimes approximately around day 13. Once that occurs, the body starts producing the RBC, WBC, and platelets on its own. Till then, we have to give supplemental RBC and platelets. So that initial period where the patient has no immunity, if he has a very bad infection, it could kill him. 15 years back or even 10 years back, the mortality was somewhere close to around 8 to 10% during induction. That is during the transplant itself. It used to be called TRM, or transplant-related mortality. Now with better supportive therapy, better antibiotics, better blood products which are available, that transplant-related mortality has come down to less than 2%. Any good center, as of today, will have a TRM or a transplant-related mortality less than 2%. So at least around 100 patients who undergo transplant, less than 2% would not make it. We keep a value of around day plus 30. So up till day 30, we do this calculation. That is still they are out of the transplant unit. Around 98% of these patients pass beyond day 100, and a huge chunk of them pass beyond 1 year, 2 years, and 3 years as well. So this is regarding the safety. So for that 1 month which the patient is inside the transplant unit, it takes around 1 month. He will be with an attender. He should not be able. We should be ensure that he's in a clean room, doesn't contract an infection either from the attender or from the nursing staff or the doctors who visit, or from the environment itself. That's why we put them into a clean room. So that's the infected part. What are the infections? It could be bacterial, viral, or fungal as well. Now, outcomes and recovery. So that all depends on the cancer type. In myelomas, you almost reduce the tumor burden to a very low extent, and then afterwards for the next we put them on maintenance therapies. So at least for 4 to 6 years, in a lucky condition, even beyond that, that cancer doesn't come back. It may come back later in multiple myelomas, but you have good and more therapies at that point in time which you can salvage the patient. In lymphomas, the cure rate is somewhere close to around 60%, 60 to 65%, where the disease won't come back after doing the transplant. In acute leukemias, the cure rate is again between 40 to 60%, depending on the risk stratification to begin with. If the person had a very high risk leukemia, then the chances of salvage or the cure is around between 40 to 50% after giving the bone marrow transplant. In a patient with a low risk leukemia, the success rates are above 60%, 60% chance of cure, that the disease will not come back. In many of these diseases, we identify certain markers, driver mutations, and put these patients on post-transplant maintenance therapies, either in the form of tablets or in the form of injections. Historically, large number of patients were doing bad in the past. They have been doing very well now. So, my dear friends, it's bone marrow transplant is something which was an enigma in the past. Now it is a day-to-day affair as of today. Many of our hospitals indulge in it, like our hospitals at Gleneagles BGS. We've been doing transplants for the last 15 years in this organization, and we've had very, very good success rates. And world over, it's not just our hospital, world over, many of our colleagues have been doing very, very well, and we've been having fantastic outcomes. Because very important is we need to keep ourselves abreast with the latest knowledge, learn, relearn with every patient and every case that we handle. With this bone marrow transplant, which was a very tumultuous affair in the past, has become a very challenging and a very, very good and doable entity in the present. Thank you.